You walk into your shift and your assignment includes a chest pain patient just brought in by EMS, a post-ictal seizure patient that is confused, another in CHF who's borderline needing BiPAP, and another room that's wide open and ready for business. You're asking yourself, what do I do first? What do I prioritize? How do I even stay calm? The truth is, the ER is fast, unpredictable, and overwhelming, especially in the beginning. But with the right mindset, a solid foundation, and a clear understanding of what to expect, you can show up prepared and confident. To help you do that, this video will walk you through exactly what you need to know before starting in the ER, from must have skills and critical thinking tools to common complaints, assessments, and high risk conditions that every new emergency nurse should be ready for. So let's get into it. And as always, thank you for watching. Let's start with the mindset because this is going to shape your entire ER experience, especially in the beginning. First, you're not going to know everything, and that's okay. You're not expected to be an expert on day one. Even experienced ER nurses are still learning and asking questions. So don't waste energy trying to be perfect. Focus on learning and building a solid foundation of emergency nursing principles. Next is going to be to manage your expectations. It usually takes about a year before you feel remotely confident in the ER. That's completely normal. The best ER nurses aren't the ones who know everything, they're the ones who stay humble, are calm and collected, and are calm and collected, especially in critical situations like a code, an MI, or even a seizing patient. Your job again is to stay calm. When things are chaotic, your calmness will help you think clearly and act with purpose. Whether you're in a code, managing a stroke alert, or preparing for intubation, your ability to stay focused is often the most important skill you can possess as it allows you to use what you know efficiently. Next is going to be to be proactive, not reactive. Don't wait for someone to tell you what to do. Always ask yourself, what can I do right now to move my patient's care forward? Do you need to get the Ativan ready for your patient who's seizing? Do you need to grab RSI medications and get them ready for your patient who's going to need intubation? Do you need to prime the blood tubing for the patients whose hemoglobin just came back at 5? Do you need to place a second IV for one of your critical patients? Do you need to call chest x-ray after a central line was placed in the chest? Anticipating the needs makes you an asset to your team and ensures that your patient receives the best care possible. Being proactive, again, prevents complications. It helps you stay ahead, and by doing so, you are prepared to handle whatever comes your way. And finally, confidence is built through repetition and reflection. You get better by showing up, by trying, by learning from your mistakes, and by doing it again. If you miss an IV, don't beat yourself up. Ask yourself, was it my angle? Was it my angle off? Did I not pull the skin tight enough? Was it not taut enough? Should I have used two tourniquets? What could I have done differently so that I can do it better the next time? That's how clinical confidence is going to be built by learning from every patient, from every shift, by asking yourself, how can I be more efficient next time I have a patient like this or are presented with a similar situation? Next, let's move on to the clinical into the clinical foundation of every emergency assessment. The ABCs, right? Whenever a patient looks sick, unstable, or something just feels off, or when you first come into contact with them, your first step is always going to be the ABCs: airway, breathing, and circulation. This framework helps you spot life threatening problems fast and guide urgent interventions. A is for airway. Ask yourself, is the airway open and protected? Listen for sounds like stridor, gurgling, snoring, or complete silence, all of which can signal obstruction or compromise. Look for things like facial trauma, vomiting, drooping, or altered mental status, all signs that the patient may not be able to protect their own airway. If the airway isn't open or protected, you need to act. You need to do a head tail chin lift, a jaw thrust, suction, insert an NPA or OPA, and if you're unsure or if it's beyond your scope, call immediately for help. The more brains, the better it is for your patient so you can figure out what's going on. And the provider or the team needs to be at the bedside to ensure the patient receives the appropriate intervention, including even if RSI is needed, right? They need to come so they can get that done. Airway, again, always comes first for a reason. And if the patient, again, if the patient is speaking and they're yelling at you and it's loud and clear, Of course, the airway is open at that point. B is for breathing. Ask yourself, is this patient breathing adequately? Don't just rely on the SpO2. Look at the respiratory rate, work of breathing, and use of accessory muscles. Are they breathing shallow? Are they tripoding? Do they look tired or cyanotic? You might need to escalate from a nasal cannula to a non-rebreather or even a bag valve mask support. In more serious cases, again, non-invasive ventilation, intubation, needle T, and even a chest tube if the patient requires it. C is for circulation. Ask yourself, are they perfusing well? Check the heart rate, blood pressure, skin color, capillary refill, temperature, and mental status. Signs like cold extremities, delayed cap refill, or a sudden drop in blood pressure are going to be red flags. Mental status changes can be one of the first signs of poor perfusion. And if circulation is compromised, get IV access quickly, start fluids if appropriate, monitor vitals closely, and ensure the team is aware and going to respond promptly. Does this patient need blood products? Do they need pressors, or is it just fluids? What else do they need? And again, of course, if there is no pulse, move into ACLS, which starts with good high quality CPR. And remember, mastering the ABCs allows you to act fast and prioritize what matters most. Now, let's get into another important ER essential, the vital signs. Every patient gets a set of vital signs. It helps us determine how sick they are and assign a priority level, plus gauge whether our interventions are working or not. You need to know when a vital sign abnormality is truly an emergency, such as a heart rate more than the 150s or less than 50-ish, SpO2 less than 92%, and respiratory rate higher than 20 where they're showing signs of increased work of breathing, and SBP higher than 180s, but especially anytime above 200, and any time less than an SBP of 100 or even 90. Of course, these are going to be general rules of thumbs from what I've seen, but if a patient looks unstable, such as pale, diaphoretic, about to pass out, it doesn't matter what their vitals look like, they must be prioritized. Each patient presentation is different, so let the vitals help you. But again, you're treating the patient, not just the numbers. So it's a whole picture that you need to evaluate and base everything on your clinical judgment. For the heart rate, you should know the normal, of course, is 60 to 100, but trends and context matter more than just the number. If it's high tachycardia, think about what's causing it. Is it pain causing it? Is it fever, anxiety, hypovolemia, sepsis, or even an arrhythmia like SVT or AFib RVR? A high heart rate won't start causing instability until it reaches well over 125 to even well over 150 in adults, right? So if your patient's heart rate is ever higher than 150, that's a priority that needs to be placed in a bed and evaluated ASAP. If it's slow, bradycardic, ask, are they on a beta blocker, a calcium channel blocker? Could it be a heart block? Did they vagal down? Some patients will be athletes that are well trained and have low heart rates, but these patients often don't go to the hospital. So when in doubt, treat it as an emergency and get the patient seen, especially when the heart rate is less than 40, especially if the heart rate is less than 35, they should be in a bed immediately and prioritize. For blood pressure, watch both the ends of the spectrum because either can be super serious. A high blood pressure, again, look for a headache. Are they having chest pain with it? Are they having any neurological symptoms? It could just be the pain that's causing their hypertension, but it could also signal a hypertensive emergency, a stroke, or even an aortic dissection. So if a patient comes in with an SVP above 180 and are complaining of a headache, shortness of breath, chest pain, I am going to assign them a higher priority because this could be a true emergency. Remember, a high blood pressure can damage the heart, the brain, the kidneys, and even lead to stroke. On the other hand, a low blood pressure, always consider shock, bleeding, infection, and so forth, and dehydration as well, just to name a few. Check perfusion, full skin, delayed cap refill, augmentation. Those are all signs that circulation is compromised and this patient needs to be prioritized. For respiratory rate, again, the normal 12 to 20. If it's high, consider hypoxia, metabolic acidosis, sepsis, or just even anxiety. If it's low, be concerned about opioid overdose, neurosuppression, or impending respiratory failure. For the SpO2, again, normal 95 to 100. But if it's low, think about why. Is it COPD, pneumonia, pulmonary embolism, CHF, or an airway problem? and place them on oxygen immediately. Remember, a non-rebreather is your best friend for patients who are hypoxic on arrival as it provides 100% FiO2. Of course, if they need assistance with respiration, a BVM valve mask is going to be the best way to go. And for temperature, a fever might point towards an infection and sepsis. A low temperature, especially in elderly or immunocompromised, can also be a sign of sepsis. And in the winter months, don't forget about cold exposure. Again, vital signs are extremely important in the ER. You need to know how to interpret them and how to use them to care for your patients. Look at the whole picture. If something doesn't match what you're seeing, trust your gut and ensure they are prioritized and seen faster, or at least get a second nurse with more experience to look at them, or even just get the provider immediately. Now, let's talk about the most common ER complaints, the ones you're going to see on every shift. Even if these seem routine, they can all still represent life-threatening emergencies. So chest pain is never something to take lightly. You always need to consider serious causes like myocardial infarction, pulmonary embolism, aortic dissection, or even a pneumothorax. You're going to ask the questions: where is the pain? Does it radiate? When did it start? What does it feel like? Are there associated symptoms like shortness of breath, dizziness, sweating, or nausea? And look for a pale, diaphoretic, or anxious appearance. Look also for an abnormal ECG or even an elevated troponin. All these are signs that this patient is sick and needs all the attention. As the nurse, your priorities are going to be to place him on the monitor, to get a 12 lead ECG within 10 minutes, to start an IV, send the labs off, including the troponin, and again, be ready for that chest pain protocol that your facility may have, such as aspirin, nitroglycerin if it's not a right sided MI, and oxygen if needed. And prioritizing if this patient is having a STEMI, going to the cath lab. Next is going to be shortness of breath. Shortness of breath again can be caused by asthma, CHF, PEs, pneumonia, sepsis, and even an MI, just to name a few. This is going to be a wide differential for the providers. So your assessment really matters. You're going to ask, is it sudden or gradual? Does it get worse when lying down or with activity? Any fever, cough, chest pain, or recent travel? Look for signs like labor breathing, nasal flaring, or use of accessory muscles. Look for a low SpO2 or abnormal lung sounds like wheezing and crackles. And make sure that you get a good past medical history of respiratory and cardiac illness. For nursing priorities, if they're hypoxic, again, apply oxygen, listen to lung sounds, place them on the monitor, and obtain a full set of vital signs. Get a detailed respiratory and cardiac history and be ready for imaging, for labs, and an ABG if ordered. For altered mental status, it's going to be also a broad differential for the providers. It could mean a stroke, it could mean hypoglycemia, drug overdose, trauma, sepsis, metabolic issues, just to name a few. So it'll be broad, but your main questions are going to be: what's their baseline mental status? Are there any recent changes to their medications or any substance abuse? Do they have a history of diabetes, seizures, strokes? Again, getting a comprehensive picture of what's going on with the patient. You're watching out for unresponsiveness, slurred speech, and seizure activity. You're watching out for unequal pupils or signs of trauma or intoxication. Your first actions are going to be to check a point of care glucose immediately. Ensure the airway is protected. Start an IV, put the patient on the monitor, and draw labs. Get an ECG to rule out cardiac issues, and perform a neural assessment to rule out a stroke if stroke is suspected. And if it is suspected, if a stroke is suspected, notify the provider immediately and prepare for a code stroke activation. Know the last known well time, that a head CT would be among the most important things to get done, again, to differentiate between an ischemic and hemorrhagic stroke. And a pro tip for these altered mental status patients, again, is always going to be to check the point of care glucose first, because if hypoglycemia is the cause, it's going to be the easiest thing to fix. For abdominal pain, again, abdominal pain is going to be one of the most common and easily underestimated complaints in the ER, but it could be a ruptured appendix, a GI bleed, ectopic pregnancy, or even an abdominal aortic aneurysm. So ask the right questions, get a full set of vital signs, and keep in mind important risk factors like females of childbearing age, chronic alcohol use, prior abdominal surgeries, or a history of esophageal varices, and old age. You're going to ask the onset, the location, the severity, and whether it radiates anywhere. You're going to ask about associated symptoms like nausea, vomiting, fever. bowel or urinary issues. For females, again, you're going to ask about the last menstrual period and pregnancy possibility. You're going to look for guarding, for distension, for rebound tenderness, and signs of early shock for these patients, like a low blood pressure or high or heart rate, pale or cool skin. And for your nursing priorities, you're gonna again get a full set of vital signs and a pain score. If the patient presentation deems it, you're gonna start an IV, draw labs, and prepare for imaging. Keep the patient NPO until evaluated, and the provider can tell you otherwise. And again, for the females of childbearing age, run a pregnancy test. Now, let's get into ESI, sepsis protocol, and the key high risk conditions you need to know. ESI, the Emergency Severity Index, helps the team decide who gets to be seen first based on how sick they look and how many resources they're going to need. ESI level 1, you're going to think of needs immediate life-saving interventions. Think of cardiac arrest, severe respiratory distress. For ESI 2, it's high risk or very abnormal vital signs. Think of stroke, think of sepsis, think of chest pain with shortness of breath. For ESI level 3, you're thinking more stable, but they're going to need multiple resources like imaging, labs, and IV medications. Again, for ESI level 4s and 5s, you're thinking more low acuity, simple procedures, no workup is needed. Understanding the ESI helps you prioritize care, anticipate orders, and understand why some patients are fast tracked and seen faster than others. For the sepsis protocol, know that it's important because sepsis is subtle at first, but it can be deadly if missed. Look for a suspected infection. So you can look for a suspected infection plus 2 or more abnormal vital signs. Are they febrile? Is their heart rate above 90? Is their respiratory rate above 20? Did their white count come back elevated? You're going to watch for a low blood pressure, for altered mental status, and for an elevated lactate in these patients, as it can show as that is a sign of hypoperfusion. For your nursing actions, again, start an IV, draw a lactate level, draw blood cultures before the antibiotics, and get fluid and get the antibiotics started quickly. And of course, notify the provider right away. With sepsis, the faster it is recognized, the faster the antibiotics and fluids are on board, the better the outcomes. Now let's go over some of the most important high-risk conditions you're going to see in the ER. You must know how to recognize them, the complications associated with them, and the key treatments that make a difference. So the first is going to be congestive heart failure. Look for shortness of breath, crackles, leg swelling, pink frothy sputum. These patients are often hypertensive or fluid overloaded. The treatment includes oxygen, BiPAP, nitroglycerin, and diuretics. For strokes, the signs are going to be facial droop, slurred speech, weakness, and numbness on one side of the body, and can be altered as well. Time for these strokes is critical. Initiate the stroke alert and get a CT head ASAP. A CT head helps differentiate between an ischemic stroke and a hemorrhagic stroke. For thrombolytics, the time frame is 4.5 hours if there's no contraindications, and is 4.5 hours from symptom onset. Thrombolytics are only for ischemic strokes. You would kill if you give a patient thrombolytics for hemorrhagic strokes, because that would make the bleeding worse. Again, only for ischemic strokes. And always ask about the last known well time. Get a weight early on because thrombolytics are weight based. Get a point of care glucose to make sure hypoglycemia isn't causing these symptoms. And obtain a set of vital signs early on and repeat them often. For an asthma exacerbation, there you're going to look for signs of wheezing, tripod position, labor breathing. Here, the treatment is albuterol, Atrovan, steroids, and magnesium. And you're going to assess for improvement of lung sounds after treatment to gauge whether more treatments are needed. For atrial fibrillation with a rapid ventricular response, you're going to look for irregular rapid heart rate and symptoms like dizziness or shortness of breath or even hypotension to show that this patient is unstable. For the most important actions are going to be to get an EKG, put him on the monitor, get an IV, and prepare to give medications like Cardizem and Metoprolol. For hyperkalemia, you're going to look for these patients who are on dialysis and they miss their dialysis. That places them at a high risk for it. For Sandra, you'll look for muscle weakness and tingling. On the EKG, you'll look for peak T waves and a widening QRS. For the treatment for hyperkalemia, you're thinking calcium gluconate, insulin with a D50 amp, sodium bicarb, Lasix if they still make urine, albuterol if they're not tachycardic, and Lokelma at some point, and of course, dialysis. For seizures, you're going to protect their airway. You're going to time the seizure, observe the movement and the duration, of course, and you're going to prepare to give medications like Ativan and Keppra afterwards. You're always going to check a point of care glucose and prepare for the post-ictal state, which is going to include confusion and can even include agitation. And if the seizure persists and the patient is in status, you're going to prepare for intubation. For brain bleeds, you're going to monitor for severe headaches, for vomiting, and for changes in neuro status. Your priorities are going to be to notify the provider immediately, prepare the patient for a head TT, and be ready to manage the blood pressure as parameters for these patients are often in SBP less than 140. And of course, again, promptly communicating changes. Does the patient need an EVD or additional neurosurgery interventions? That's why promptly communicating is important. For SVT, you're going to look for a rapid, narrow, complex rhythm with the heart rate typically above the 150s. And typically, from what I've seen, is 170, 180, and even sometimes well over the 200s. And it's typically going to be just a sudden onset. The treatment includes vagal maneuvers if the patient is not super unstable. Prepare again adenosine, and if the patient is unstable, going immediately into cardioversion. For an MI, for a STEMI, look for again chest pain, diaphoresis, and ST elevation in consecutive leads. You're going to activate the code STEMI if your protocol or facility allows it, or make sure that the provider is at bedside and is able to interpret the EKG. For these STEMI patients, you're going to apply oxygen, administer aspirin, and nitroglycerin if it's not a right-sided MI, and be ready to transfer to the cath lab. And also be ready for the rhythm to change into a VFib at any time, so place the pads on these STEMI patients. For a hypertensive emergency, you're thinking severe BP elevation with symptoms. You're thinking, do they have a headache, any vision changes, chest pain, or are they dizzy? And you're going to get them on the monitor, assess again for neural changes to make sure it's not something else, and prepare to administer IV antihypertensives. For a pulmonary embolism, you're thinking shortness of breath, chest pain, tachycardia, and hypoxia. You're going to ask about recent surgeries, immobility, or a DVT history. As the nurse, your role is going to be to get them on oxygen, to monitor them closely, and to anticipate imaging such as a CT chest angiogram. And in order to do so, you must place a large bore IV in the AC so that the pressure of the contrast can go into this IV. And the treatment will, of course, include anticoagulation such as a heparin drip. And if it's big enough and causing the patient to be unstable, a thrombectomy. For a pneumothorax, it's a sudden one-sided chest pain, decreased breath sounds, and in a tension pneumothorax, you're going to think tracheal deviation and hypotension. You'll alert the provider and prepare for immediate decompression with needle T and for chest tube placement. For a GI bleed, you're thinking vomiting blood or black tarry stools and hypotension. Priorities are going to be to start large bore IVs to monitor for signs of shock and prepare for transfusions. To know how to use the rapid transfuser of your facility, are they also going to order octreotide, protonics, and Rocephin? Will the GI team come down to the ER and scope the patient? Do you need to know how to manage a Minnesota tube? And for DKA, another very important condition in the ER, symptoms include nausea, vomiting, a fruity breath, and confusion. Remember, Kuzma respirations, a blood glucose typically above 250, and electrolyte imbalances and abnormalities. For the important treatments is going to be IV fluids, monitoring their glucose, make sure that you're keeping an eye on their potassium, that you're checking the gap and electrolytes every 4 hours, that you're checking the glucose every hour, and you prepare to put him on an insulin drip per your facility protocol. And by the way, if you're finding this helpful and want to save time and energy with mastering the chaos of the ER, check out our book and course. They're packed with everything you need, including foundational material, practice tests, and tips to help you become a confident and competent ER nurse. Links are below in the description and pinned comment. Now, let's go over the basics of safe and efficient documentation. The first is going to be objective, not opinionated. Your charting should always reflect what you observed, not how you felt or what you assumed. A good example is this patient reports 9 out of 10 chest pain, clutching their chest. And you're not going to say something like, patient exaggerating symptoms because that's subjective and that's judgmental. So stick to the facts. If in doubt, quote the patient directly and describe behaviors objectively. But again, be objective, not opinionated. Again, for your charting, be focused. The ER charting is not typically a full head to toe unless it's relevant, but keep it problem focused. Focus on documenting your initial impression and assessment, the interventions. What did you do for this patient? How did the patient respond? And ongoing reassessments, especially after medications or after changes or after interventions. You're going to prioritize the chief complaint, normal vital signs, pain scores and response, procedures performed, education, and anytime the provider went and updated the patient or the plan of care was changed. Again, chart what affects the care, the safety, and decisions that are made, and skip all the fluff. Stick to what actually matters when charting. And if you're able to chart in real time, when you can, I know the ER is busy. Sometimes you're just going to have to write things down on a piece of paper and chart at some point when you can. So again, throughout the day, try to update your chart as you can, especially after interventions, after giving medications, or after seeing changes in condition. But again, do not prioritize charting over patient care, especially in a critical situation. At that point, you're just going to write a quick time, a quick word that's going to refresh your mind later on so that when you sit down, you're able to have the times of when everything happened. And a key reminder, if you don't chart it, it did not happen. Again, always chart what you saw, what you did, what you communicated. And if you notify the provider, document what you reported. For example, the BP dropped or the heart rate went up or this lab is this. Document who you spoke to, what they said, and what they ordered. What was the response? This not only supports continuity of care, but it also protects your license. Now, let's talk about hands on skills, the practical things you should focus on early so that you can master these and become more confident. So, the first is going to be placing IVs and lab draws. You're going to be starting IVs and drawing blood on a lot of patients and often in tough circumstances. So where know where to go for good IVs, the AC, the back of the hand, the thumb side on the wrist, the medic vein, even on the shoulder for these difficult patients. You're going to practice and you're going to have plenty of experience with elderly patients, with obese patients, with dialysis patients, with drug users, patients who are in shock and hypotensive. These type of patients are going to be the hardest to place an IV on. Don't forget, place two tourniquets, tap the area, and let gravity help you fill the vein up. Another important thing is going to be to know how to run a 5 lead ECG, of course, as far as like placing them on the monitor on the 5 lead, and how to do a 12 lead ECG correctly, knowing where to put all the stickers and all the leads. You're going to need to learn how to recognize rhythms like a STEMI, VTAG, AFib, bradycardia, and so forth, and know again when to alert the provider and how to describe the rhythm clearly. You're going to need to monitor and know how to provide the basics of airway management because again airway is always going to be your first priority. Know how to apply and switch between a nasal cannula, a non-rebreather, a valve off mask, and how to assist with placing a patient on BiPAP. Be able also to help during intubation, gathering medications, suction, setting everything up, knowing the typical doses, knowing how the position of the patient helps the provider intubate more easy, how to monitor the patient during the intubation, and how to monitor for complications. Practice proper BVM technique, two hand seal, appropriate rate, and watching for chest rise. Also, know about your crash cart and defibrillator. During a code, your crash cart is going to save lives, especially if you know what's going on with it. Know what's in each drawer, where the pads are, where epinephrine is, where the flushes are, where the airway tools are, where the backboard is, where all the medications and everything in it. Learn how to apply the pads, know how to defibrillate, know how to use the synchronized cardioversion, and know how to switch to pacing for bradycardia, such as a third-degree heart block that's unstable. And remember, always call clear before defibrillating anybody. Other important skills are going to be knowing how to use a central line and arterial line. These are going to be common in critical patients. Know what ports go where, know how to keep everything sterile and secure, know how to zero an art line, and watch for complications such as bleeding, dislodgement, air embolism, and signs of a pneumothorax if a lung was punctured during the placement of the central line. Know how to use a rapid transfuser or level one, whatever your facility has, because some patients are going to require a lot of blood products quickly, especially trauma patients and massive GI bleeds. So learn how to set the rapid transfuser or level one up fast. Learn how to use the filters, know how warming works, and how to use the tubing, and know the common transfusion ratios. How many red blood cells versus plasma versus platelets should patients be getting? And one of the most other important ones is to know how to use your facility's IV pumps. Every nurse needs to master the IV pump. Learn how to set the rate and volume, time the tubing, and troubleshoot it when you need to. Know how to handle occlusion alarms and air in line errors, and even know how to find the right medication. Now, let's wrap it up by talking about what really leads to growth and for you to master emergency nursing. Again, what does it really take to become a great ER nurse? First, focus on progress, not perfection. You're not going to feel confident every shift. You're going to make mistakes, you're going to miss things, and you're going to feel overwhelmed, especially in the beginning, but that's okay. Again, first focus on progress, not perfection. What matters is that you keep showing up, that you keep trying, and that you keep learning. Second is going to be to reflect after every shift. Ask yourself, what went well? What would I do differently next time? This reflection is how you turn experiences into improvement. If you miss an IV, ran late with the medication, or even fumbled in a critical moment, learn from it and be better next time. And finally, commit to growing. No one becomes a great ER nurse by accident. It takes intention, repetition, and effort. Be strategic, take notes, watch from others, study when you can, seek feedback, and again, focus on progress, not perfection. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.